So I am Dr. Charlotte Sharfin, also known as Dr. Cha-Cha, and you are being joined, I am being joined with three amazing women that are going to help me do this talk about advanced directives during a pandemic. And we have Eddie Cash Dudley, family lawyer. We have Kim Schuler, advanced nurse practitioner with a lot of experience in ICU, family medicine, and palliative care. And then we have Bobby Bryant, end-of-life doula extraordinaire and trainer. And just so you all know, everybody talking tonight, we're all end-of-life doulas that were trained under Bobby. So just a few things I want to mention, just housekeeping kind of things. This session is being recorded. So we cannot see your faces, but we wanted to have this available to people that could not make it, also so that you're able to watch it later if you want, and then you can also share it with people. Please do. We will take questions, as many as we can. So please put that in the Q&A only. I know there's a place to raise your hand, and I know there's a chat box, but just so I don't get distracted, this is my first webinar leading. So just put every question you have in the Q&A, and then when we're done with our presentations, I will answer. We'll all try to answer as many of the questions as we can. Okay, and so just a little bit about Life and Death Wellness. That is our nonprofit. We are established in the state of Hawaii. We have a small center up in a very small part of the island, on the Big Island in Kapa'au. And, you know, our mission is really to empower life through teaching around all life matters, but especially the end of life. And people ask me all the time, why the name Life and Death Wellness? And what I tell them is, I'm an emergency physician. I've been that for 20 years. My number one job is to walk into a room and decide whether somebody is living or dying. That's it. And then there's a whole bunch of stuff that comes afterwards. What my patients taught me was that it doesn't really matter where you are in your stage of life. You could be terminal or you could be chronically ill, and you can have wellness in so many different ways. It's not just housed only in the physical body. And so our mission, our idea, our hope is that we can offer more availability to just have the conversation around that D word that a lot of people tend to avoid, the word death, so that it does empower life. So I'm really excited to bring this talk about advanced directives during a pandemic. If this pandemic has not woken people up yet to really make them realize how important it is to really express their wishes, I'm hoping this talk will. I think you've all either seen it on TV or you have maybe already had some kind of personal experience. If you develop COVID-19 and you're one of those people that get critically ill really quickly, there's not a big window there to have these conversations. The other types of people that I think about are people that are living with chronic disease, or they're in advanced age, and they may not want the standard of care that you're going to get when it comes to COVID-19. So we're going to talk about all of that. And so we're going to start with Eddie Cash Dudley. She's going to lead this talk. So Eddie, when you're ready, please go for it.
Of being here today and sharing with you such a very important piece of information about choices that you can make regarding your end of life. There are a lot of legal aspects to an advanced healthcare directive, and on the next slide you will see that it allows you to make the choice about who will make the decision. And this only becomes effective if you become incapacitated. So while you're able to make your own choices, of course you make your own choices. But if you're incapacitated, and it could be an automobile accident, it could be that you're in an irreversible coma, you're in a situation where you're unconscious, there's no hope of ever gaining consciousness again, you have the right at that point to have the person that you've selected make the choice for you. It won't be the state of Hawaii or whatever state that you're living in that tells what the rules are regarding that, but it will be somebody by your choice. And it's also a way to let your family know what your end of life are. There are so many situations where people do not share their end of life wishes, and you can see them in the hospital care facilities, people wringing their hands. What would mom want? What would dad want? How would they want this to happen? So this is your ability to show a lot of compassion and what your choices are. One of the legal aspects on the next slide will be who is your next of kin. So if you the one who will be my next of kin, you're sadly mistaken, because under Hawaii law and most laws of most states, it's only your legal spouse. Even if it's a legal spouse that you haven't lived with for a number of years and they're on the other side of the nation, they still are your next of kin. And they will be the ones who will be contacted if a decision needs to be made about you. Second to your legal spouse would be your children. Now, Hawaii and most states, except some in the South, have common law marriage. So if you've lived with somebody for a long time, they're not your legal spouse. And states only recognize children by blood. So if you have Hanai children, that's what they call children here in Hawaii who are raised by people other than their parents, those are not your legal children. And then it goes to your parents and to your siblings. So if you make a choice on who's going to make the decisions for you on your end of life care, that choice trumps the law of every state. And the next slide is really relative to people who are at end of life. They're at a point where they need to go into some sort of convalescent facility, care facility, and they own a home. And the Advanced Healthcare Directive that we have created with the help of Bobby Bryant and primarily from Heather Reynolds, an estate planning attorney in California, we have the language in there that Medicare requires in order for them not to sell your home to pay for your long-term care. So if you're looking at the Advanced Healthcare Directive that is being offered to you free of charge today, and one of the sections in there says, I intend to return home. It is my intent to return home. And that language itself will protect you from Medicare coming in, selling your home, and using that money to pay for your care, because what if you recover and you end up back in your home? And so that's the protection that we offer in that Advanced Healthcare Directive. And the next slide is some of the things you might want to consider. And for example, it's pretty standard on an Advanced Healthcare Directive to name your spouse or one of your children. And then as an alternate, maybe another child or maybe a good friend. But sometimes it's very, very difficult for one person to be the only one to make that decision. There have been a lot of situations where families have shattered at that decision. They've splintered at that decision because only one person was named to make the decision, and there's always somebody who has a second opinion. And what you don't want to do is be in a situation where one person makes the decision and then everybody else never speaks to them for the rest of their lives. So one thing I'm suggesting is that you name not only more than one agent, but you name maybe two agents at joint and several, which means that one agent decision if the other agent happened to be across the United States and wasn't available to be there. But if they're both there, then it would be a joint decision. Or you could also name a committee. So you could have 2 or 3 people. I recommend a committee where there's blended families. For example, if I have a blended family, I have children that are not my husband's, he has children that are not mine. We have one child between us. My committee is 2 and my husband. If I just named my husband and he made the decision to terminate life support for me, that could really offend my children. So having a committee to make your decisions, I think, is a good thing to consider. And that option is available. It is available on your Advanced Healthcare Directive. The Advanced Healthcare Directive that you're going to be looking at also has a HIPAA release. So if somebody needs to talk to your doctor about your medical condition, the person who's named on your Advanced Healthcare Directive has the right to get your medical information. It has the medical aid in dying provision, if that would be one of your choices under those particular circumstances. It also has palliative sedation, if that would be an appropriate choice for you. And it also has the disposition of your remains. In fact, there are 6 ways to get buried in Hawaii, and they're all 6 listed, and all you have to do is check the box. So if you're interested in this type of information, we're going to be doing another seminar in September. I will be leading that one. To be how to do your own will. how to do it on your own, how to use a sample will that Dr. Sharfin is going to make available on her website. You will need to newsletter so you can get information about that. And we look forward to talking to you again and thanking you so much for joining us today.
Thank you so much, Eddie. I so appreciate it. And we will talk more about that advanced directive that Eddie's got for us. It's amazing. And probably one of the most detailed ones that I've actually seen. So again, I'm Dr. Cha-Cha, and I am, I've told you I'm an emergency medicine physician. I also have my own private practice. I do urgent telemedicine as well as treat patients that are chronically ill and at the end of their life. But what I'm going to be talking to you guys today about is the medical aspects of the advanced healthcare directive and some of the things I think that are important to know that really aren't in the directive, but that are coming up because of this pandemic. I know a lot of you have heard about ventilators and CPR, so I just want to make sure you understand it all. But traditionally, I want you to understand that modern medicine teaches us that death is a failure, okay? That we have to do everything to keep people alive, and if we're not able to do that, we have failed. And we know that's not true. Death is natural. But what is going to happen if you do not have an advanced healthcare directive, if you've never talked to anyone about your choices, is we are going to assume that you want everything done, and that is what's called a full code. Okay, and I'm going to go into what CPR looks like in ventilators. I know you've all seen it on TV. You've seen people pumping on the chest when someone dies, and then they all of a sudden miraculously wake up. And that's not really how it happens in real life. Every once in a while you get one of those patients and they're amazing, but typically that's not the case. So CPR stands for cardiopulmonary resuscitation. That is only going to happen if your heart stops, okay? It is an emergency life-saving procedure. When your heart stops, basically what really happens most of the cases that are out of the hospital is the heart goes into either a fibrillation or just does these little funny things where it's not actually physically pumping, right? So you're not getting oxygen to your brain. You pass out within a few seconds, then you stop breathing. And if CPR is not started immediately, or at least within minutes, you will die. So basically that's called cardiac arrest. And that happens every 90 seconds to one American. And typically it is outside of the hospital. And if you have a cardiac arrest outside of the hospital, your chances of survival are not like they are on TV. Okay, most people, if you took 100 people that had a cardiac arrest, 90 of those will die. 90 of them that make it to the hospital will not leave. If you took the 10 people that make it and that they live, only about one of them are going to actually leave with their brain intact. The other ones will be usually significantly disabled. So that's why CPR is so important to do immediately. That's why the American Heart spends a lot of time teaching and a lot of money goes into the research. But statistically, unfortunately, these statistics haven't changed. If you were to have a cardiac arrest inside the hospital, it is a little bit different. But if you are seriously ill, meaning if you have, say, a terminal cancer or you're over about the age of 80, your chances are even less. So I get asked the question often about COVID-19 and CPR. So first of all, we don't have statistics from the US as to what the mortality is yet. We do know it's bleak. We do know it's not pretty, and it's probably going to be somewhere probably around that 2% survival, but we don't have that. So what I tell people when we're talking about COVID-19 is you have to understand why the person is going into cardiac arrest. And so if the person has COVID-19 in the hospital and their organs are all starting to shut down, and then they go into cardiac arrest, their chances of survival, even if we bring them back, it's not good because we're not changing what's already taken place. So I like for people to understand there's a difference in COVID-19 specifically and out of hospital cardiac arrest that the American Heart teaches about. Okay. But that's something that would be done unless you've elected not to have that done. The other thing people, I think, hear a lot about are ventilators, right? You've seen where we are putting people on ventilators because they're going into respiratory arrest, basically. But what does that look like? What does that mean? And so this is a technique that it was called an advanced airway procedure, endotracheal intubation. It's something that I do commonly in the emergency department to save lives. Paramedics do it, ICU doctors do it, respiratory therapists do it. You want somebody that's really trained in this procedure. As you can see in the slide, you're really in somebody's face. So this this has a lot of risk. When you hear about doctors and nurses and other people getting really sick from COVID-19, a lot of these procedures are the ones where we have to be extremely careful. But basically, we use a scope. I look in, I'm looking for your vocal cords, and then I'm going to place a plastic tube into your windpipe, or what's called your trachea. And that's when you get attached to the machine or the ventilator. And that's what's blowing the air and the oxygen through that tube into your lungs. We do this when someone cannot support their own breathing, and we've tried everything else. That is standard practice. That will happen to everyone unless you have said otherwise that you do not want that. Okay. When it comes to COVID-19, the other thing I like people to understand is what is the tracheostomy. So I know you've seen stories where people are on ventilators for prolonged periods of time, right? Well, you can't just have that tube in for more than about 2 weeks. You get a lot of complications from that. So what will have to happen is a small incision will need to be made through the skin of the neck, and then surgically you will enter the windpipe or the trachea, and a surgeon will place a smaller tube called a trach tube, okay? And then you're attached to the ventilator. And that is for people that are going to have prolonged stays in an ICU, either from COVID-19 or other complications. A lot of our comatose patients will need a trach. I think of our ALS patients, different patients could potentially need a trach. The question I get often is, but what if I don't want to be on a ventilator? Then what? If I don't want a ventilator, can I still be treated? And absolutely you can. When it comes to COVID-19, we're going to do everything we can to prevent you from going on the ventilator. So we're going to use those non-invasive types of procedures. And we're going to do this for other diseases as well, like asthma and COPD and the other reasons people end up on a ventilator. So that's high flow oxygen, that's oxygen masks, there's breathing medications we can give people. If somebody is absolutely against getting on a ventilator, there's medications that we can give to soothe the anxiety that goes around the shortness of breath and the pain. But I do make it clear to all of my patients that choose not to, it could be their death. And if they're okay with that, that is the wish that I am going to respect. But they also have to understand how critically ill they are. So when it comes to COVID-19, if you are being, if a loved one is being put on a ventilator, it is because they are not able to support their breathing. And I think it's something that people, especially with advanced age and chronic illness, really need to consider around this. And so how do you do that? This is brand new. This has not been around for very long. How do you address COVID-19 in an advanced directive? And so there is something called a COVID-19 addendum. I have sent you the link if you signed up a few days ago, but I will send it again. There's several out there. The one that I actually really like is put out by Compassion and Choices. But there's more. So you could actually literally just Google COVID-19 addendum and find the one that you really like. But it can be attached to any advanced care directive. So if you are one of the people that's already written one, it doesn't mean you have to go back and do a brand new advanced directive. You can attach this. You have to follow your state's guidelines. And depending on what state you're in the state of Hawaii, you just need 2 witnesses. In other states, you may need to have it notarized. I always just recommend getting it notarized if you have that ability. But it really specifically only addresses your values around if you were to develop COVID-19. And I'm not going to go through the whole addendum, but I love the way Compassion and Choices lays theirs out, because basically it asks, if you were to develop this and you were to get sick, would you want to go to the hospital? That's the number one question, right? Do you want to stay at home, or do you want to go to the hospital? If your oxygen levels are dropping, if you can't be supported by non-invasive measures at home, do you want to go to the hospital? If you do, and the doctors cannot keep you comfortable and keep you alive without putting you on a ventilator, do you want that? And if you do want that, do you have any parameters around that? What if your organs start to fail and you have to be put on dialysis? Would you still want to be on a ventilator? What if you needed to have a feeding tube placed to keep you alive? Would you still want to be on a ventilator? Do you have a certain amount of time, weeks, months? Or if you write all this down and these are your wishes, does your healthcare advocate have the power to reverse all of them if the doctor says, you know what, we think we can turn this around? So I love this, especially when it comes to this pandemic. And the people that I think really need to consider this are the people that are really concerned and the people that have risk factors, right? So if you're in an area where there's a lot going on and you have chronic illness or advanced age, this may be something you want to consider. If you are somebody that wants everything done and you don't have an opinion about it, you don't need to fill this out. One more thing I do want to mention, because I do get asked this a lot about people that do not want aggressive treatment or invasive treatment. So advanced directives, everybody should have them. I just believe that wholeheartedly. I don't care if you're 20 years old and you're perfectly healthy, you need to at least name somebody to speak for you. But what if you, again, are advanced age, or you have a terminal illness, or you have a chronic illness, and you are opposed to the things I just talked to you about? CPR, ventilators, feeding tubes. If you specifically absolutely know you do not want that, or under certain circumstances, you need to do more than just an advanced healthcare directive. In the state of Hawaii, we do something called a POLST, which is called a provider's order for life-sustaining treatment. It's that green sheet, but this is I'm looking at it right here. Every state's different, unfortunately. Florida has a DNR, but it allows someone to choose. I do not want CPR, but I do want intubation. I do not want CPR. I do not want intubation, but I'd like to have fluids. I'd like to have antibiotics. I'd like to have pain medication. I do not want anything. I just want to be comfortable. So that is really important for one big reason. It becomes a medical order. Okay, an advanced healthcare directive isn't. If 911 gets called and you don't want these things, but you don't have this filled out, they're usually, under most states, they're obligated to resuscitate you. Remember, death is a failure. You're considered a full code unless you've done something about it. So this only applies to people that do not want things. I do not want ever to give the impression that if you're perfectly healthy and you want everything done, do not fill this out. It will confuse EMS and it will confuse me. When we see this means somebody's elected not to have full treatment, and we want to respect those wishes. Okay, and I'm going to leave you with that. I do believe, yep, and then we're going to go on to Kim.
Thank you, Eddie and Charlotte. Such great information. My name is Kimberly Schuler. I am a nurse practitioner. I'm board certified in family practice. I've been in the medical field for about 12 years. Spent 5 years at the bedside as an RN in the intensive care unit. I've spent the last 5 years in primary care. And I'm also currently obtaining an advanced practice certification in palliative care. This topic today is really near and dear to my heart, particularly with my experience in working in the ICU at the bedside. Really saw some of the devastations that it can occur when people don't have advanced directives in place, and patients and families of patients wishes aren't known, and there's just a lot of suffering, I think, that can be eased when those choices are made in advance for everyone involved. What I'd like to talk with you today a little bit about is the subspecialty of palliative care and how I think it can very much support people with chronic illness or serious illness, and particularly in the case of a pandemic like COVID, and as well with supporting the creation of advanced directives. So first, a little bit about palliative care. Palliative care, and this is extrapolated, these bullet points, from the CAPC definition of palliative care. It's the Center to Advance Palliative Care. I recommend that website for anybody who wants more information. Palliative care is a specialized form of medical care for anybody living with a serious illness. It focuses on providing relief from the symptoms and stress of the illness. So this includes physical symptoms, psychological side effects, spiritual issues, social and cultural. So it really, palliative care focuses on treating the whole individual. The goal of palliative care is to improve the quality of life for both the patient and the family. So palliative care considers the patient and the family actually as a unit, as being treated. It really recognizes that the interdependence of family dynamics and relationships as being important in quality of life. And palliative care is really a team effort. So it's a team of specialists that work together with the patient's other doctors, providing an extra layer of support. So usually you'd have like a a medical doctor or a nurse practitioner, along with a social worker, a therapist, chaplain, or other spiritual advisor, caretakers, doulas, and sometimes art therapists and things like that. Palliative care is really based on the needs of the patient and not just on a prognosis. So it's really, you know, if you think of somebody who goes into the ER and their heart stops, like something that Charlotte does, there's an algorithm. You give CPR, you give certain drugs. Palliative care is basically like the opposite of that. So the treatment is really going to be so individualized, ideally based on what that particular person and the family needs, what they find important. And it really just treats holistically and not just the symptoms and physical disease. Palliative care is appropriate at any age and any stage of an illness. So anyone young to old can get sick, and palliative care can be there to support. And really, palliative care is appropriate at any stage of an illness, from like diagnosis, particularly if you have like a progressive illness. Ideally, the palliative care team would be there with you from the beginning. Now, whether that's covered by insurance or things like that, sometimes that's not the case, but we're hoping that will change and that we can help support that. And again, another big thing is palliative care is actually provided along with curative treatment. I think there's a lot of belief palliative care as a subspecialty is fairly new. So there's a lot of belief and stigma that palliative care kind of means you have to give up curative treatment or anything that you're already doing, and it's absolutely not the case. Again, it's designed to be an extra layer of support on top of what you're already getting. And so just based on that, I wanted to kind of give a little bit of a difference between palliative care and hospice, because I think also a lot of people just kind of equate palliative care and hospice as the same thing. So hospice is a subtype of palliative care, but with hospice, that is a shift from curative treatment to comfort-focused care. So for hospice care, you would no longer be seeking curative treatment for that primary illness, and the goal would be to create optimal comfort and quality of life. And then with hospice, you would have, to qualify for hospice, you need to have a prognosis of 6 months or less to live, and there's no prognosis requirement for palliative care. Okay, palliative care and COVID. So palliative care can be given, sometimes you'll see palliative care units in the hospital, sometimes outpatient, but also one of the ways palliative care can be given is have that team kind of come to a home setting. So in an instance like when we're having a pandemic like COVID, having that increased care and support at home, or even through telemedicine, but having that extra layer of support can really help keep people maybe from going for treatments that they might not need or having to go to the ER. Studies have actually shown that palliative care can help decrease ER visits, hospital admissions, ICU admissions, and length of stay. And in some cases, it's been shown it can even prolong life in advanced illness, in addition to improving quality of life. Again, with that team dynamic, hopefully being there with you throughout the illness, part of that should be education. And as the illness trajectory changes or symptoms change, or if there's a progression, or if there's changes, say, in what we know about the pandemic, which seems to be changing every day, you can really discuss with that team the risks versus benefits of maybe going in for treatment or trying to work more at home with symptom management and care. And then along with that, which I'll get to in the next slide, is just along with those changes, you can update the advanced directive if needed. So that was the last thing I wanted to discuss, was just palliative care and advanced directives. Really, the palliative care team is in an ideal situation to help support determining goals of care. What is the most important to you and your family to create optimal quality of life? So not only having that relationship, but then also being able to translate that into an advanced directive that then can direct the healthcare that you would want if you can't speak for yourself. So as you might be able to tell, I have a lot of belief that palliative care can be a great support for so many people. And it is our hope at the Life and Death Wellness Center to create a really strong, supportive palliative care team that can help support the island, hopefully for people, whether they have support through insurance or not. But that is a goal of ours. And thank you for your time, and I'll send it off to Bobby.
Thank you, Kim, Eddie, and Charlotte. Aloha, my name is Bobby Bryant. I am on the board of Life and Death Wellness, and I'm an end-of-life doula, and I facilitate end-of-life doula trainings here in Hawaii as well as on the mainland. Soon we'll be providing those trainings online. I have a background in working with hospice in managing volunteer services and training volunteers to support people who have a terminal diagnosis. So what is an end-of-life doula? End-of-life doulas provide non-medical, holistic, physical, emotional, and spiritual support for those who have a terminal diagnosis. We provide options and education to assist the dying in having their end of life unfold in alignment with their values and wishes, to preserve their quality of life, well-being, and dignity up till the very last breath. We offer support, comfort, and compassion so the dying and their loved ones feel safe and supported during this sacred transition. For the ancient Greeks, the term doula usually meant a female servant who helped the other women in the household perform tasks back then seen as women's work. With the emergence of end-of-life doulas, the definition is changing to include both women and men. Similarities between birth doulas and death doulas are not accidental. Just as laboring mothers can benefit from a doula who is there to comfort and support them through labor, dying patients need support and comfort as they labor out of this life. Doulas have traditionally been companions and guides for those coming into this world, and now do so for those leaving this world. End-of-life doulas will work side by side with everyone on your healthcare team, including hospice, nurses, alternative healthcare practitioners. We strive to support people in having the best quality of life possible, moment by moment, day by day, until you're ready to cross over. Planning, planning, planning. So, we tend to plan for weddings and graduations and bat mitzvahs, but as a nation, statistics show that we don't tend to plan for our last chapter of life. This can result in a lot of confusion and perhaps not getting the medical care that you would have wanted should you have made those important decisions and had them documented. Lack of planning puts a lot of stress on those who will have to eventually make those end-of-life decisions for you should you choose not to do so for yourself. So doulas are all about helping people to make plans, and so are trained to assist people with advanced care plans, quality of life plans, and end-of-life plans. So with advanced care plans, they're really necessary if you become, critically ill or in an accident or unable to speak for yourself. So think of them like a roadmap for your medical care that other people can follow. Without this roadmap, there can end up being a lot of wasted time and energy getting lost inside our fractured medical system. Think of end-of-life doulas as being a part of your GPS system, helping to point you in the right direction. End-of-life doulas can help you understand what your options are and provide you with additional resources to also assist you in making these decisions. We help facilitate conversations with family concerning your wishes as well. Quality of life plans. So end-of-life doulas support people in having the best quality of life possible. We don't focus on illness, but on wholeness. We help people create quality of life plans based on their values and what's really important to them, and then provide support in creating plans for comfort, joy, creativity, community, family gatherings, health, being in nature. Whatever it is that causes a person to feel fully alive and to thrive until they're not. At a certain point, we all slow down, but even within a slowdown time, quality of life plans take into considerations like, where are you the most comfortable, and who would you like to spend your time with, and what brings you ease when things are challenging? We encourage people to do a life review, revisiting what a person has been experiencing since they arrived on this planet. A life review also allows a person time and space to examine regrets, unfinished business, grief and shame, and to share in this with family and friends as a way of creating a deeper bond. A life review actually does help support a good quality of life as people become free of some of the baggage that they've been carrying, as well as revisiting important experiences, relationships, and milestones in life. They can value the life they've lived. We can have a meaningful life until our very last breath. What does that mean? That we're connecting with whatever is deeply important within us and around us, even when things are challenging. Connecting might mean having important conversation with loved ones, or the great mystery with spiritual guides, gods, and goddesses, or your pets. Because end-of-life doulas help to create a complete network of care, life becomes less stressful and therefore enhances the patient's quality of life along with the caregiver and the family, as the effect of doula support provides a ripple effect that can help everyone feel a little more at ease during a challenging time. End of life plans. So, doulas like to encourage people to create something that they will leave behind for those who love them. And this is different than a legacy, which tends to assets. Creating more heartfelt creations, for instance, a video of you speaking about your life and what's been meaningful to you while you've been here, or an ethical will where you write your thoughts on important lessons you've learned in your life for your children or your grandchildren. Or write love letters to people that will be given out once you've passed on. Someone who loves cooking might create a book of their favorite recipes and stories of events and family gatherings where those dishes were served, along with photos. So family and friends can create those recipes from that book for years to come while being reminded of their loved one through the photos and stories in the book. The last days. So we like to help make plans for the last days and weeks for optimal comfort. We support people in considering things like, if this is the place where you spend the most time, can you create a sense of beauty and comfort and be surrounded by what is meaningful for you in that space? Maybe photos of family, friends, and art. Is your bed in the best possible place? Maybe you want to look outside and see a particular tree and birds that arrive there every day. Maybe the lighting needs to now be softer, or you want more natural light. What are the sounds that you want to hear? Birds, the Kohala winds, music? What kind of music? Maybe a recording of your grandchildren's laughter. And what do you want? Who do you want to visit you, and who don't you want to visit you? Because of COVID-19, we are often limited as doulas who we can go see. And so we are supporting people over the phone and Zoom. And because right now we are living in a place where the virus count is lower, there are some of us who are going out, but we are masked and fully gloved, just like all healthcare professionals are. And for family who want to be with those that are dying, they're also doing that on Zoom now, and this can be an equally, not as intimate as if you were actually there, but it can provide a sense of intimacy as well. So after death care, doulas help to remind people that once death has happened, it's not an emergency. And you can take your time with the loved one before making necessary phone calls, which the doula can also make for you. Before the Civil War, we used to care for our elderly and the dying in our homes. And when they died, we laid them out in the parlor and we washed their bodies, and we did rituals that were extremely important, as well as putting, a favorite outfit on, and putting cream on the body, really tending lovingly to the body of the loved one. And then family and friends would come and talk story and sing and talk about memories. So we're doing that these days as well. Home funerals have gained in importance for people, so you can have a home funeral. And then end-of-life doulas also help people understand what will happen with their body, the options that they have for disposition of their body once they've passed. So I've been given the signal that I need to wrap it up. So the trouble is, you think you have more time. And the fact is, we never know when we're going to die or become critically ill. And so planning is of extreme importance. So please plan, please do your advanced care directives. Thank you so much. I'm sorry, I have one more thing to say. If in donating to Life and Death Wellness, what you will be also donating towards is to help people that live in our community and on our island who might not be able to afford end-of-life doula support, to be able to have that kind of support. So we want everybody to be able to have this kind of support. So by donating, you will be participating in creating a fund for those who don't have who do have financial need. Okay, thank you.
Also, I want to add, this is one of the things we're offering is if you have not created your advanced healthcare directive, or if you just need to review it, we have doulas that have volunteered their time to do that with you. So we will have an email that goes out. I'm on the list, so is Eddie. Everybody here is on the list, and then we have a few other doulas that are willing. So if you need help with an advanced an advanced directive, then please reach out by the link that I'm going to send you guys, and we are going to be more than happy to work with you via Zoom, via the phone. We do have the center. We can actually, if you're on island, we can meet here as well. So please be aware of that, and you'll get more information about that. And now we're going to take questions because, yes, I want to respect everybody's time. And bear with me. I'm going to try to look at all of the questions, but the first one that I got was to Eddie. And that question is, can you explain more about the Committee for End-of-Life Decisions that you mentioned at the beginning of the talk?
As I mentioned earlier, that it frequently is a good choice when there's a blended family. So it's not just on one person when there are children involved, maybe from another relationship or another spouse. Another situation where it is designated as your agent is pretty young, and it would be really overwhelming for that person to have to make the choice of suspending life support, terminating life support. And in that kind of situation, you may want a friend or a family member, a sister or brother, niece or somebody to be on that team with your son or your daughter, just because you would feel like they needed the support if somebody said to them, are we ready to pull the plug? And so about 3 people on it, and it would be a majority vote, but the person who is designated number 1 would have the last say. So it is really a compassionate way of providing support for the people that you want to make those end-of-life decisions for you. Thank you.
Thank you. And there's a follow-up question to that that says, how do we access the free version of the Advanced Healthcare Directive being offered tonight? I'll answer that just because I'm doing the I'm not doing the back end stuff. My amazing assistant Jude is, but Eddie's been so kind to offer that for free. And so what will happen is anybody that signed up for this webinar, even if you weren't able to attend, you will get a follow-up email. There will be this Advanced Healthcare Directive that Eddie is talking about. I'm also going to attach the COVID-19 addendum. And then, I don't know, next week, probably you'll get another link that'll actually have this recording. So you'll get all of this. And if for some reason you don't, just hit me up and I will make sure you have it. Okay, good. I think that takes care of that. Let's see. Wait a minute. Hold on. Oh, okay. You mentioned a directive that you thought was a really good one. Will you share with us what that is? Will it be compatible for California use? Eddie, you might actually want to answer that question since you started your practice in California. So the directive that we're talking about that we're going to be sharing with everyone, the question is it compatible for California use?
It absolutely is compatible to California use. If you live in another state, the only thing you have to do is to go to the section of the Advanced Healthcare Directive that says this shall be applied, the laws of the state of, instead of Hawaii, write in any other name of a state that you want. It has all of the elements Healthcare Directive requires, but it also has a lot of end-of-life planning information. And in Hawaii, it can be signed by 2 witnesses or it can be notarized. And those forms for witnesses as well as for the notary are going to be in what you're going to be receiving from Charlotte. So you can use. Thank you.
We missed the last end of what you said, but absolutely, I'm going to send this to everybody so you have it. And let's see, the next question is for Kim. And it's about palliative care on our island. Do we actually have access to palliative care on the Big Island?
Yeah, good question. Well, I'll start answering that by kind of discussing the insurance coverage with palliative care. This isn't exhaustive. There's so many different potential insurances and private insurances, but the main ones that do have a palliative care benefit are UHA, HMSA, and then the VA. The VA is kind of its own system. They do concurrent care anyways. So basically they don't really have a separate hospice. They just always have the option to have curative and palliative treatment together. HMSA has a benefit with stipulations that someone has a certain amount of debility and their illness is advanced to a certain degree. And then they also have, you can only have benefits for 90 days in any rolling 12-month period for HMSA. So once that 90 days is up, you don't get any more palliative care for another year. UHA has concurrent care. From what I can tell, I don't see that they have a 90-day stipulation, and I couldn't find direct information on the qualifications necessary. So that being said, both of those, the UHA and HMSA, if you have that benefit, it's required to be done through a certified hospice. So both North Hawaii Hospice and Kona Hospice does offer this through the insurance benefit, and the Hilo Hospice does as well. And my understanding is Hilo also has a separate palliative care program where they provide that benefit for people, or they provide palliative care for people who don't necessarily have the insurance coverage. But here on this side of the island, North and Kona side, as far as I know, there's not another separate palliative care service.
Let's see. Dr. Chacha, this is for me. I have heard that many COVID-19 patients do not survive the ventilator. Your thoughts? Yeah, I have a lot of thoughts about this. You're right. There are many people that don't. I know everybody's heard the cases of where one, you don't survive it, or either you have a prolonged experience being on a ventilator. What I will say is we have come a long way from the beginning of this. When we first started this, I was actually stuck in Florida. I had just taken a trip from Hawaii. It was spring break. And then I found myself in the middle of a pandemic and asked to work in the emergency departments over there. We were taught early on, put them on a ventilator, put them on a ventilator. Best thing you can do is put them on a ventilator. We now know that's actually not accurate. We're going to try to keep people off ventilators as long as we can. The people that will tend to do worse if they end up on a ventilator, you probably have heard this, but are going to be people that have a lot of medical issues. So morbid obesity, chronic medical condition, and advanced age. These are people that will have a hard time coming off a ventilator, and that's why that addendum is out there. So if you know that this is not your choice, this is not something you'd want to go through, then you can opt out of that if that's what you want. When we talk about people less than 50, they've got definitely a better chance. If you're 20, definitely a better chance. Of course, there are cases across the board where even young people don't do well. There are cases across the board where blows my mind, people that have chronic illness, terminal illness, have done fine with COVID-19. So that is why I think, one, you need to really think about what your wishes are. Two, you really need to share that with your advocate, and you need to name them, because this is such a dynamic, changing thing. And so you've got to have somebody that can take in this information, understand it, and make the choices that you would want, or either you need to put those in writing. Okay. And let's see, the next one. This is for Bobby. Do you all do a COVID risk assessment for those you serve? If so, what all do you do or ask? Turn on your microphone, Bobby. We cannot hear you.
Yep. Thanks. That is a really good question, and very important right now. We're extremely careful these days. And initially, before we go see somebody, we talk on the phone. And so we ask people questions specifically about COVID, about where they're at, about who's around, who has been around. And if people are not feeling well, then we make sure that, we recommend that they go get tested if, it's somebody in the family that's come to visit. So we are very, very careful about this right now. And we do that assessment over the phone. And then if we are going in and seeing people in person, again, we're masked and gloved, and we're assessing every time we're in there what the conditions are.
Thank you, Bobby. And we're still really fortunate. We are so extremely fortunate. We don't have as many cases on the Big Island. I hope we keep it that way, but we'll see. I think you probably guys all know that Oahu is going into total shutdown again tomorrow. Here's another question. I will answer this one. I have heard about high flow nasal cannula being used in Europe along with a mask to protect medical professionals as a replacement for being intubated. Is this available here on the Big Island hospitals? This is available at every hospital. So this is when I talked about non-invasive procedures to try to keep people off a ventilator, this is exactly what we would do. So you have to have a room that is set up to do this. I work in North Kohala. We have this. So we're a tiny, tiny emergency department. Yes, I think the Big Island's taken this a lot more seriously than a lot of places in the United States. But yes, it's standard of care now. We really do not want to put people on ventilators if we can avoid it. So you will get high flow oxygen. You will get BiPAP or CPAP. You will get steroids. You will get as much as we can give you. And then if none of that works, then it's the choice of a ventilator or not. Okay, let's see. Here's another one for Eddie. If you choose the committee, best to have an odd number, no ties, question mark. Your thoughts on that?
I think it's best to have an odd number so that there were no ties. And usually it defaults to the number one person if there is a dispute. And it will default to the number one person. But having an odd number is a choice that I would make.
Beautiful. Let's see. Oh, here's another. This is another one for you, Eddie, actually. Are the words "I intend to return home" in this directive? This is a new recommendation for me, and I don't think 5 wishes, which is what I've mostly used, has this wording. Can you comment on that, Eddie?
Yes, I can. I intend to return home is in this advanced directive, and I'm trying to find which page it's on, but those words are specifically in there for that purpose. And I want to thank Heather, an estate planning attorney of 20 years in California, for recognizing that that became an important way to protect clients. So it is in this directive.
Thank you. And that is the first time I've looked at a lot of advanced directives. I actually personally had used 5 wishes in the past for my own personal advanced directive. And when I saw Eddie's, I was like, oh my gosh, this goes into even more detail than the 5 wishes. And so I appreciate that about that. The other places you can get directives in Hawaii, I just want to make this clear for people that are completely young, healthy, and don't need a lot of detail. Go to Kakuamau. They've got our Hawaii Advanced Healthcare Directive. It's very basic and easy. If you're someone that has a lot of medical issues, questions, concerns, use Eddie's, use 5 wishes. There's a lot of them out there, but thank you, Eddie. Let's see. What else? Okay, one more for you, Eddie, and then I'm gonna have to move on. If property is already in a realty trust, no fear of property getting sold to pay back medical bills. Is that correct?
I don't know the answer to that, so I'm not going to answer it.
Yeah, you know what? That might be a really good follow-up for our next one when you're talking about more of the financial, the legal aspects. So, okay, we'll skip that one.
Yeah, I'm not familiar with realty trust, so that's why I'm not going to answer it.
Okay, I'm spoken like a true lawyer. So this was a question that came to me. A person that lives in Hawaii, families in Florida, they are a do not resuscitate, and I was told they got absolutely no care. Is there a way to make sure that they get care? So to me, that's a travesty. And that is one of the reasons I brought up the Pulse. Florida, unfortunately, doesn't have this, but Hawaii does. MOLST is another word for it. There are a lot of places that actually, a lot of states that actually use this. And so if you are a person that has decided you are a DNR, a do not resuscitate, that means you do not want intubation, and usually you do not want CPR. You should still be getting medical care based on your wishes. And that's why the Pulse is really important, but you can still put it in your advanced healthcare directive. And what I tell people is, what does that mean to you? What kind of treatment would you want? Would you want comfort care? Most people do. Make comfortable without pain, pain medication, anti-nausea medication. Do you want IV fluids? Do you want antibiotics? So there are ways to make sure that people absolutely get treated. Just because you choose not to get resuscitated does not mean you should not be getting medical treatment based on what your values are. Okay, and I am, let's see. Oh, Bobby, how do you find a doula, and are they part of hospice care? And then we're going to wrap this up very quickly because we've been going for about an hour.
Okay, so are they a part of hospice care? North Hawaii Hospice.
Doula, sorry. How do you find one, and are they part of hospice care?
Okay, yeah, so North Hawaii Hospice is the only hospice on the island that has end-of-life doulas. And they're big supporters of end-of-life doula care. And how do you find an end-of-life doula? Well, contact me. You can email me. My information will be in the follow-up letter, and that's for this island. I'm creating a directory for end-of-life doulas that I've trained on this island and off island, but you can also, on the mainland, you can go to an organization called the National End-of-Life Doula Alliance, and they have a directory as well.
Perfect. All right. I think we are going to wrap this up. Eddie, if you want to say a few words, I'm going to say thank you after everybody's done, but gosh, thank you for your attention. Go ahead, Eddie. Maybe. Unmute yourself.
Well, we want to say thank you for joining our seminar today, and we hope that we've given you some information. Most importantly, we hope that we've encouraged you to start to think about the things that you need to do that are important to you and important to your family. We'd like you to tell others about the program, tell others about the life and death wellness, and make donations. And if you want to join the mailing list, the information is at the bottom of the screen that you're looking at right now. And the reason that we want you to make donations is we want to continue to provide education to the community about issues of wellness. We also are looking for donations so that when somebody wants an end-of-life doula and they just can't afford to pay for somebody to come, that will be made available through your donations. So please put your name on the mailing list for Dr. Sharfin. You again. We will be doing another seminar in September. I will be teaching you how to write your own simple will that's perfectly legal, and that will also be free of charge. So if you want to keep seeing the pretty faces that you're looking at today, send some money. And I think Dr. Sharfin is going to tell you just how to send it. Thanks.
Thank you, Eddie. Yeah, so you will actually get an email from us. It's going to have, again, the resources. It's going to have a link to, if you want to use volunteer end-of-life doulas, there's always a link to donate. You can go on our website to www.ldwellness.org. There's a donate button there. You can also join the mailing list there. Please share this video when it goes out too if you found it helpful. If you have other questions and we didn't get a chance to answer them, send us an email, info@ldwellness.org. And yes, Eddie's going to be talking in September about wills. We also have in October, we have an amazing physician that's going to speak to us about psychedelics at the end of life. He's a psychiatrist that's done a lot of research out of Colorado. He's made a lot of changes in laws over there. So every month we are hoping to bring you really interesting talks, really valuable talks. And yes, we want to bring the ability to have end-of-life doulas on our island. We want to be able to have palliative care for everyone, even the uninsured. We've got lofty goals. Ultimately, I'd love to have a place where people can come and they can actually die in a peaceful setting where it's not medicalized, where they are surrounded by people that can support them. So thank you if you can donate, and if you can just support us by joining the email list and telling others any of that. We're just grateful. We're grateful in general that you took your time to listen to everything we had to say. And we're going to call it a night. Aloha. Thank you.